So we're starting with the anterior shoulder exam. We are looking for the biceps tendon to start with. My first landmark is going to be the bicipital groove with the greater tuberosity laterally and the lesser tuberosity medially. I'm going to have my patient positioned palm up on their thigh and elbow at their side. It's important to keep the tail of the probe flat and not angulated up or down, otherwise your anatomy will look falsely pathologic. So once we find the biceps tendon at the bicipital groove, which is here, it's nice and bright, we can follow it down to the pec tendon, which comes across the screen here to insert on the medial side of the bicipital groove. At this point, we're just looking for fluid around the biceps tendon and the tendon integrity. We can follow the biceps tendon all the way up to the rotator interval. At this point, I'm going to have my patient put their hand in their same side back pocket. Go ahead and palm flat on in your pocket. There you go. Angling my probe towards the belly button. So the biceps tendon is the bright oblique structure more medially, with the rotator cuff arcing over the humeral head on the right side of the screen. All right, go ahead and relax. Now that and palm up on your thigh. Now that I have found the biceps tendon in short axis, all the way from the pec tendon all the way up to the rotator interval, I'm going to find it in long axis. So I'm going to put it in the middle of the screen and rotate the probe here. Putting more pressure on the inferior part of my probe to make sure the humerus, which is the bright linear line at the bottom of the screen, it's flat across the screen. If I don't, it angulates down and it looks pathologic. So if I put more pressure, the fibrillar pattern of the biceps tendon is nice. We're just looking for fluid and biceps pathology at this point. All right. Now we can move to the rotator cuff. I prefer to start at the anterior rotator cuff. I slide up and medial to find the coracoid, which is the half moon shaped hyperechoic structure on the right side of the screen. I slide lateral to find the humerus, where the subscapularis is inserting on the lesser tuberosity. I'm going to have my patient rotate about 45 degrees in external rotation and follow that tendon out. Go ahead and pause. So the subscapularis is a really broad tendon, so we want to make sure we follow it all the way down till it disappears and all the way up till it disappears. And once we're satisfied that we have evaluated the whole tendon, we can turn in short axis to find what's called the lima bean appearance of the tendon. There are many tendon bundles of this tendon. We want to make sure we see all of them. Again, sliding superior and inferior as well as medial and lateral to evaluate the whole tendon until it disappears, which is about right there on this patient. Go ahead and relax. Similarly, we can look at the subacromial subdeltoid bursa at this location. It extends quite anteriorly. We want the coracoid on the right side of the screen and the humerus on the left, and you can have your patient externally rotate and internally rotate, looking to see if there's any hypoechoic fluid passing between the humerus and the coracoid in the bursa, which there is not on this patient. Go ahead and relax. And then we're going to look at the posterior rotator cuff. You're going to have your patient put their hand in their opposite back pocket. Good. And again, angulating towards the belly button, starting at the coracoid, because that's as medial as you can get in the shoulder, and slide lateral and around the shoulder till you see the check mark appearance of the supraspinatus. And then continue to slide lateral till it flattens out to predominantly infraspinatus, and then continue lateral and around till it gets even flatter, which is the teres minor, and most patients often have a cortical irregularity at the insertion of the teres minor right there. That's normal. That's a vascular channel, not pathology. Once we find this in long axis, I prefer to slide back to the supraspinatus, spin 90 degrees to find it in short axis. It should resemble a tire or a head with hair on it. And it should be even. If you're concerned about a rotator cuff tear, if there is a quote-unquote flat tire appearance, where it's not an even distribution of tendon to humeral head, it may indicate a rotator cuff tear. And again, slide medial and lateral to ensure you're seeing the whole tendon, as well as superior, until it disappears. This can be an uncomfortable position for patients, especially if they have an acute injury or just a painful shoulder in general. So this may take some time, and your patient may need to come out and shake it out and then go back to this position. If they cannot get in this position, they can go same side back pocket, or even supine with their arm extended off of the table, depending on your patient's capabilities. Go ahead and relax. And go back, palm up on your thigh. Good. Now we can evaluate the acromioclavicular joint. As clinicians, this is pretty easy to find. We just palpate, put the probe down, and there it is. Two hyperechoic lines with no signal being sent back, so most of the screen is dark, with a gap in the middle indicating the acromioclavicular joint. If you don't find it here, you can always slide lateral to find the acromion and the humerus, and then just slide medially towards your patient's head. And there it is. This is one that we always stress. You can stress it a couple of ways. My preferred way is resisted elbow flexion. Go ahead and push into my hand. Good, and we're just looking to see if that joint moves, gaps, or if the clavicle, which is the structure on the right side of the screen, if it deviates superiorly or superficially. Once we find the AC joint, we can slide lateral to evaluate the subacromial subdeltoid bursa again. So our landmarks in this screen are the acromion and the humeral head with the posterior rotator cuff attaching to it. And there's a thin hypoechoic or dark line in between two thick bright white spots. In about the middle of the screen, that is the subacromial subdeltoid bursa surrounded by peribursal fat. What we're going to have our patient do is elevate their elbow in about 45 degrees of flexion, so it's a little bit more anterior. And we're just going to watch. Go ahead and go back down. Watch as that passes under the acromion one more time. Good. So now the greater tuberosity has cleared the acromion. There's no fluid bunching. Good, and relax. We can even spin our probe 90 degrees, so we're now oriented more anteriorly, and then have our patient forward flex their shoulder and watch for the same thing. Back down. And the direction you do this in, one more time. The direction you do this in is dictated by the range of motion that your patient is painful in. If they're painful in forward flexion, you will scan in this direction, whereas if they're painful in abduction, you'll do it in this direction.